Hemorrhage, Kuckel tool known as bleeding, is defined as the escape of blood from a blood vessel. In oral surgery, this phenomenon can occur due to damage to the vasculature, which is essential for delivering oxygen and nutrients to tissues. Understanding the basics of hemorrhage is crucial for clinicians, as excessive blood loss can quickly become life-threatening. Post-operative bleeding in oral surgery often originates from either soft tissues or bone, such as nutrient canals or vascular lesions like hemangiomas. Recognizing the critical thresholds for blood loss is vital, since exsanguination blood loss sufficient to cause death can occur if bleeding is not promptly managed. This scene sets the stage for a comprehensive exploration of hemorrhage and shock management in oral surgery. Hemorrhage can be classified based on the vessel involved, timing, volume, and location. Arterial bleeding is characterized by a pulsatile, brisk, bright red flow emitted in jets, while venous bleeding is dark red and steady. Capillary bleeding appears bluish bright red and is usually controlled by simple gauze pressure. Timing-wise, hemorrhage can be primary, reactionary, or secondary, each with distinct clinical features. Volume classification ranges from mild to severe, and bleeding can be acute or chronic. Location-wise, hemorrhage may be internal, concealed within body cavities, or external, escaping through skin or mucosa. This classification helps clinicians quickly identify the type and severity of bleeding, guiding appropriate intervention. Blood loss beyond certain thresholds can be life-threatening. In oral surgery, mild hemorrhage is defined as less than 500 milliliters, moderate between 500 and 1,000 milliliters, and severe as more than 1,000 milliliters. The Advanced Trauma Life Support (ATLS) classification further divides blood loss into 4 classes based on percentage of total blood volume lost. Acute bleeding refers to massive loss in a short span, while chronic bleeding is slow and prolonged. Recognizing these thresholds is essential for timely intervention and preventing complications such as shock or exsanguination. Clinicians must be vigilant in monitoring blood loss during and after oral surgical procedures. Hemostasis is the body's mechanism to stop bleeding and involves 4 sequential steps. First, the vascular phase triggers vasoconstriction to reduce blood flow. Next, platelets adhere to the damaged endothelium, aggregate, and form a primary hemostatic plug within seconds. The coagulation phase activates the clotting cascade, resulting in fibrin formation that strengthens the plug. Finally, clot organization and retraction stabilize the fibrin meshwork, eventually leading to clot resolution. Understanding these steps is fundamental for clinicians, as disruptions in any phase can lead to excessive bleeding or clotting disorders. This physiological process is the foundation for both natural and clinical management of hemorrhage. The coagulation cascade consists of 4 key reactions. The intrinsic pathway is initiated on negatively charged surfaces and involves factors the 12, the Ext, the Ext, 9-9, and is screened by partial thromboplastin time, the 12.T. The extrinsic pathway is triggered by tissue factor release, forming a complex with factor 7 and calcium, and is screened by prothrombin time, PT. Both pathways converge to activate factor X, leading to the common pathway where prothrombin is converted to thrombin. Thrombin then converts fibrinogen into fibrin, which is stabilized by factor 13A. These reactions ensure the formation of a stable clot, preventing further blood loss. Clinical evaluation of bleeding risk begins with a thorough history. Key questions include personal or family history of bleeding tendencies, previous surgeries or dental extractions, history of hematuria, gastrointestinal bleeding, epistaxis, menorrhagia, and easy bruising. Underlying systemic conditions such as cancer, collagen, vascular disease, or hepatic insufficiency should be considered, as well as current medications like anticoagulants and antiplatelet drugs. Dietary habits may also influence bleeding risk. This comprehensive evaluation helps identify patients at risk for excessive bleeding during oral surgery, enabling tailored management strategies. Several laboratory tests are used to screen for bleeding disorders. Bleeding time assesses platelet function and number, with normal values between 2 and 8 minutes. Platelet count evaluates quantitative platelet status, with safe counts for minor oral surgery above 80,000, 100,000. Prothrombin time, PT, screens extrinsic and common pathways, while partial thromboplastin time, PTT, screens intrinsic and common pathways. Thrombin time. TT assesses conversion of fibrinogen to fibrin. Abnormal values in these tests can indicate specific disorders, guiding further management and intervention. Local hemostasis in oral surgery can be achieved using mechanical methods. Direct firm pressure over a gauze pack for at least 5 minutes is often effective, counteracting hydrostatic pressure. For posterior nasal or pharyngeal bleeding, a Foley catheter inflated with saline provides tamponade. Hemostat forceps and sutures are used to clamp and ligate bleeding vessels, with non-absorbable silk for major vessels and absorbable materials for smaller ones. Embolization, using angiographic catheterization and materials like steel coils or Gelfoam, is reserved for intractable bleeding. These techniques are fundamental for controlling hemorrhage during surgery. Thermal agents are another approach to achieving hemostasis. Cautery and electrosurgery denature proteins using high-frequency alternating current, which can be applied directly to clamped vessels. Argon beam coagulators transmit monopolar current via argon gas, creating a controlled eschar with minimal carbonization. Lasers and cryosurgery are used for superficial hemangiomas, with cryosurgery causing necrosis at extremely low temperatures. Advanced vessel sealing systems like LigaSure and N-Seal use computer feedback to seal vessels up to 7 millimeters, while plasma coagulation employs radiofrequency saline plasma. These methods are particularly useful for controlling bleeding from larger or deeper vessels. Chemical and local hemostatic agents play a vital role in controlling bleeding. Bone wax, composed of beeswax, olive oil, and phenol, is used for occluding bleeding bony canals, but must be used judiciously to avoid complications. Gelfoam, a purified gelatin foam, absorbs blood and acts as a scaffold, being absorbed in weeks. Oxidized cellulose agents like Oxycel and Surgicel form artificial clots and can be left in place for resorption. Fibrin glue mimics the final coagulation cascade, providing a stable framework with zero viral transmission risk. Adrenaline is a topical vasoconstrictor, used cautiously in patients with hypertension or cardiac disease. Additional agents include microfibrillar collagen, calcium sulfate pellets, tannic acid tea bags, and Morin solution. These are used for capillary oozing, post-extraction sockets, and bony cavities larger than 7-10 millimeters. Each agent has specific clinical applications and mechanisms of action, providing options for managing various types of bleeding. The choice of agent depends on the location and severity of hemorrhage, as well as patient-specific factors. These agents complement mechanical and thermal methods, ensuring comprehensive control of bleeding during oral surgery. Systemic agents are used when local measures are insufficient. Fresh frozen plasma, fresh, but contains all clotting factors and is dosed at 12-15 milliliters per kilogram. Cryoprecipitate is rich in factor VIII, fibrinogen, factor 13, and von Willebrand factor, but carries a high risk of viral transmission. Platelet concentrates raise platelet counts and are viable for 3 days at room temperature. Antifibrinolytics like tranexamic acid and epsilon aminocaproic acid inhibit clot breakdown, supporting hemostasis in patients with bleeding disorders. These systemic agents are essential for managing severe or refractory hemorrhage. Managing hemorrhage from major arteries requires precise techniques. Injury to the sublingual artery during mandibular molar extraction or implant placement can cause expanding hematoma and airway compromise. If ligation fails, the facial artery must be ligated via a submandibular approach. Incisions over the hard palate should run parallel to the greater palatine artery, and bleeding is controlled with pressure packs and tie-over sutures. The lingual artery is exposed via submandibular incision in Lesser's triangle, and blunt separation of hyoglossus muscle fibers exposes the artery. These techniques are critical for controlling life-threatening bleeding. The maxillary artery is deep and may require a transantral approach or external carotid ligation if packing fails. The superficial temporal artery is encountered in TMJ pre-auricular surgeries and is managed by direct electrocoagulation. The external carotid artery, ECA, is distinguished from the internal carotid artery, ICA, by its branches. ECA can be ligated in the carotid triangle or retromandibular fossa, but rich contralateral anastomoses mean unilateral ligation rarely creates a completely dry field. Understanding the anatomy and management of these arteries is essential for safe oral surgery. Effective management of hemorrhage and shock in oral surgery requires a thorough understanding of classification, physiology, evaluation, and intervention techniques. Clinicians must be adept at identifying the type and severity of bleeding, utilizing mechanical, thermal, chemical, and systemic methods as appropriate. Knowledge of major vessel anatomy and ligation techniques is crucial for controlling life-threatening hemorrhage. Regular screening and evaluation ensure patient safety, while advanced technologies and agents provide additional support. By mastering these principles, oral surgeons can minimize complications and optimize outcomes for their patients.